Fantastic study, very large population. I'm delighted to introduce our next presentation, Assessing Emergency Department Guideline Concordance and Outcomes After Outpatient Cardiac Stress Testing, presented by Natsui of UCLA. Good to see you. Use clicker.
Good morning. My name is Natsui. I'm a fellow in the National Clinician Scholars Program at UCLA. And this morning I'll be presenting to you our team's work on outpatient cardiac stress testing following evaluation for acute coronary syndrome in the emergency department. I'd like to thank and recognize my many and wonderful teammates, as well as my thoughtful mentors, Dr. Adam Sharp and Dr. Ben Sun. Step one. Yeah, the green one. Yeah. Great. We have no financial interests, conflicts of interest to disclose. So chest pain. In this room hardly needs much of an introduction. As we are all very much intimately aware, chest pain remains the second most common reason for ED presentation among adults in the US, with over 7 million visits per year. Furthermore, acute coronary syndrome and missed acute coronary syndrome is frequently still cited as one of the most common reasons for malpractice claims against emergency physicians. Combined with the real downstream adverse events and the risks and stakes for patients with missed acute coronary syndrome, emergency physicians have frequently cited a, quote, acceptable miss rate for ACS as much less than 1%, typically on the order of half of that. As a result, we have traditionally led to a more traditional conservative approach to acute coronary syndrome, resulting in more testing and more admissions, leading to over $3 billion in costs to patients per year. Much of this practice pattern has been in an effort to meet guidelines put forth by the AHA and ACC around evaluation for acute coronary syndrome. Specifically, the recommendation around ruling out ACS with serial EKGs and troponins, followed by an early 72-hour stress test after ED discharge as a Class 2A recommendation. The challenge has been we have limited knowledge of how easily and how frequently patients are able to obtain such testing, as well as the adverse effects associated with this. And so our team's goal was to describe rates of completion of non-invasive cardiac testing and associated major adverse cardiac events. Our setting included 13 community emergency departments in the Kaiser's Southern California network, and we looked at a time period about 13 months over 2016 to 2017. We conducted univariate and multivariate analyses around data from the KPSC EMR and claims. And our interested patient population is all adult ED patients who were seen with chest pain, who were ultimately discharged home with an outpatient non-invasive stress test ordered. Our primary outcome, again, most interested in the completion rates within 72 hours after discharge, and we also looked at when subsequently patients did end up getting a stress test if after that time period. In terms of secondary outcomes, we looked at 30-day MACE rates, as well as completion rates for different risk groups stratified by heart score, as well as we looked at relevant demographic, clinical, comorbidity, and physician data as covariates. And so just as examples, the clinical data included aspects of the visit, such as the time of day of presentation, the day of the week, which health center they were seen at. Physician data included age and gender of the practicing physician, years of practice, and whether they were full-time Kaiser physicians or per diem. So we ended up with a sample of 7,988 patients, or approximately 8,000 patients that we were looking at this question for. And then in terms of our primary outcome, we found that 31% were able to complete this testing within the guideline recommended 72 hours. Perhaps optimistically, 90% total were able to get it done within the first month after being seen in the ED. Importantly, MACE rates were low. There were no deaths among the 8,000 patients, And when you look at the leftmost column, the components of MACE with acute MI, CABG, and PCI were also all low with well below 1% event rates. Furthermore, we found that early testing, in other words, the ability of the patient to receive the recommended testing within 72 hours, did not have an impact on reducing an already low MACE rate. Furthermore, we looked at the completion rates based on heart risk score. During this time period, Kaiser Southern California instituted an EMR-based QI initiative that encouraged physicians to document a heart score at the same time as placing an order for a troponin. And so this is to be clear, a non-random sample of about a little over 2,100 patients, which is about 27% of the overall cohort. And among those patients, we see that the vast majority are low and medium risk by heart, with a distribution about 3/4 to 1/4 respectively. And that furthermore, the patient's risk score did not affect whether they were more or less likely to get an early stress test, whether that was because a physician, the ED person, or a primary care doctor was more or less concerned about them. So we see so far that none of these individual level characteristics really impacted patients' ability to get the guideline testing. In contrast, the systems level issues around where they were seen and when they were seen, which were much more important in terms of meeting these timing issues. So intuitively, if you're seen on a Thursday or Friday, you're far less likely to get a 72-hour stress test done owing to the weekend coming up, and we would all expect that. Furthermore, depending on which center you were seen at, there was a large amount of variation in completion rates. And the stacked bar graph basically is just to give you a visual sense of how, depending on which center, the 72-hour completion rates at the bottom ranged from less than 10% to nearly 70%. So in conclusion, in summary, patient-level factors did not affect the 72-hour guideline completion rate, whereas non-clinical factors on the systems level of the health center and the day of the week certainly did. The study certainly has certain limitations. We are working in an integrated health system that may not necessarily reflect every other health system. It is also retrospective analysis. However, it's a multi-center group in a large cohort in a community practice setting of what is currently being done. In terms of our conclusions and our takeaways, the first line is where we started off with. We wanted to see what the completion rate was, what the guideline concordance was among our patients. And even in an idealized setting such as Kaiser, where follow-up and referrals can be placed by ED physicians, the completion rate is still low at 31%. But regardless, the MACE rates are still low. Everything was less than 1%. And furthermore, and importantly, early stress testing was not associated with improved MACE outcomes. So in total, what this sort of leads us to question is whether we're looking at the wrong target. The initial target, the initial question was around this 31% and the ability of patients to meet guidelines. The ability of patients to meet guidelines and the concern to be able to do that is one of the driving factors behind physicians admitting patients for further workup, due to fear of loss of follow-up and other concerns. And so overall, this leads us to question whether the current guidelines are encouraging additional testing, additional hospitalizations, which lead to, as others have documented or written about, false positives, additional patient harms, patient concerns, and financial burdens that may or may not impact the ultimate outcomes that we care most about with the MACE rates. And so it calls to question whether the ACC and HAA guidelines should be revised with this particular concern. Thank you.
We welcome questions and comments.
I have a question here on the right. Maya Yadam from Vanderbilt University. This is really interesting, and I think there are many recommendations that are presented because the window sounds reasonable for considerations of physiology, but there's a systems perspective. And with your conclusion, I'm wondering if your team looked at a time to event analysis, both for when patients actually followed up and for your MACE rates, and so your MACE events, when they occurred in time. Because I think that might be where the revision of the guidelines may come from. If you can identify when, was it 2 weeks where it didn't make a difference, then perhaps instead of 72 hours, it's 2 weeks. If it was 30 days, it's a different story. And I think we all know that 72 days on different days of the week, as you presented, or 72 hours period, is challenging from a systems perspective. And so, and also availability of clinic hours and visits, and Kaiser might be a much more contained system where it may be easier for you. But is that something that you've looked at in order to inform what happens next, a time to event analysis?
Thank you, that's a really good question. This came up recently, and the quick answer is that we do have the data in terms of the time to event, but we didn't specifically analyze that yet. So I think that's an important thing as we sort of wrap up this project to look at more specifically to answer that question. The main concern, I think, the thought process we had was we did end up lumping it together more or less in terms of a 30-day overall outcome because we felt that that's what clinicians are most interested in. But you're certainly right when you take a step back. If the issue is around systems level things, then the time to event is very important. So we'll hopefully have an answer for you in the future.
Hi, Judd Hollander from Jefferson. Actually, great study, really important. I think that there's one thing maybe you could comment on that's really important, which is the rule out MI pathway, what types of troponins are being used. In the background, somebody, a bunch of gray-haired old guys in cardiology world, made up a 72-hour guideline a bunch of years ago. Maybe they were using LDH or SGOT. It's probably from the pre-CKMB era, and it's just stuck around. And although you may have the largest data set that I'm aware of, to be published, there's multiple other studies that show the same thing. There's enough data in the troponin era, particularly with the high sensitivity troponins, where this entity of unstable angina more or less disappears. A separate debate, you're either troponin positive as an NSTEMI or you're not, with very, very few exceptions, whether there's any role to do these stress tests. And I know that's where you're going towards, but in the absence of knowing what troponins were being used, it makes it harder to interpret the results. Frankly, if you're using crappier, older assays, the results are even more impressive than if you're using highly sensitive assays.
Thank you. It's a great question. My understanding is that all of the sites, and I'll have to double check this, all were using troponin eyes, but that there were no particular, each site operating individually without, for example, a uniform cardiac rule-out pathway, for example, through cardiology, but I believe they all use the same assay.
Hi, Chris Lewandowski from Henry Ford. Did you take a look at the character of the chest pain at all in terms of maybe rest angina or rest chest pain that may imply unstable lesion versus exertional chest pain that may represent a fixed lesion that may give you more time?
Yeah, thank you. In short, we did not. These were EMR and claims extractions, essentially, or analyses that essentially looked at chest pain writ large without further detail. It's certainly an interesting detail that we'd like to investigate further. We are trying to do NLP things around the stress testing reports, and so that's certainly something that we could consider looking at further.
Thank you, Shaw.
Thank you.
Wonderful.